Welcome back! If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're jumping right into a topic that honestly gets an unfair reputation. People hear medical coding and they immediately think of boring data entry. But it's actually absolutely crucial, high-stakes detective work. Every single day, complex clinical care gets translated into a precise language that dictates hospital reimbursement. And literally, one wrong word can change the whole shebang. So let's decode exactly how this system works.
Okay, here's our roadmap for today. We'll start with a quick intro to IPDRGs, look at medical versus surgical partitions, dive into ICD-10 PCS root operations, break down the impact of CCs and MCCs, and wrap it all up with clinical documentation integrity.
Let's kick things off with Section 1, getting into the macro level of MSDRGs.
So to really understand this massive sorting mechanism, you have to look at how it evolved. It didn't just appear overnight. It actually started way back in the 1980s with the original Yale DRG model, which pretty much just grouped patients by their principal diagnosis. Simple enough, right? Well, over the decades, it expanded for broader use, eventually leading to a massive update in 2008, the MSDRG, or Medicare Severity Diagnosis Related Group. Now, this was a total game changer. It didn't just ask, what do you have, but rather, how severely sick are you?
A great way to think about the MSDRG grouper logic engine is like a giant funnel. Into the top goes your principal diagnosis. That is the absolute heart of the inpatient account. But we're not done. The engine also pulls in secondary diagnoses, procedures, and demographic details like the patient's age, sex, and discharge status. All these variables swirl together in the algorithm to group the patient into a specific payment bucket based on clinical similarity and the resources they're expected to consume.
Moving on to Section 2, let's look at the first major fork in the road, medical versus surgical partitions. Once the algorithm figures out the major diagnostic category, we hit that fork. And the rule here is incredibly powerful. If a procedure is on the chart that meets the official CMS definition of a major operating room procedure, the entire case shifts over to a surgical DRG. If not, it stays on the medical side. As you'll see in a bit, the difference in reimbursement between those two paths is, frankly, staggering.
Which brings us nicely to Section 3. Let's get into the fascinating linguistics of ICD-10 PCS root operations. We are zooming down to the micro level now, where a single word changes everything. Take excision. In everyday conversation, a doctor might say they excised something, just meaning they cut it out. But in the strict 31-root operation dictionary of ICD-10 PCS, excision has a super narrow definition. It literally only applies when a segment or a portion of a body part is cut out, without replacement. Think of a breast lumpectomy or taking out a cyst. It's just a piece.
Now here's what's really fascinating. A doctor might scribble down liver biopsy, but the coding system doesn't care about common medical jargon. It looks at the actual intent and physical reality. Since a diagnostic liver biopsy involves removing a small portion of tissue, in the coding world, that falls squarely under the excision root operation.
But that begs a pretty big question, right? If excision is strictly just a piece of a body part, how does the system categorize taking out an entire organ? And why does that clinical distinction matter so much?
That brings us to resection. Resection is defined as cutting out or off, without replacement, all of a body part. So a partial nephrectomy, excision, but a total nephrectomy, resection. Same goes for a total mastectomy or an appendectomy. Even if the surgeon's notes say they excised the appendix, a coder has to interpret the reality of the procedure and code it as a resection. The system demands that we respect the difference between a slice and the whole pie.
All right, Section 4. Let's talk about the impact of CCs and MCCs on severity adjustments.
Think of these as the ultimate multipliers for a hospital's payment here. Once you have your base DRG, the system scans the secondary diagnosis. It's looking for a CC, a complication or comorbidity, or an MCC, a major complication or comorbidity. So a basic DRG like simple pneumonia pays the base rate. But if the patient also has a moderate severity CC, like malnutrition, the reimbursement bumps up. And if they have a high severity MCC, like sepsis or acute renal failure, boom, the case jumps to the highest possible reimbursement tier.
Let's walk through how this actually builds in a real-world flow. Imagine a patient is admitted for a severe infection, sepsis. That's our principal diagnosis. During their stay, they develop acute kidney injury, a major secondary diagnosis. Because of this AKI, they need dialysis, which is our procedure. The grouper algorithm takes that sepsis, adds the AKI, factors in the dialysis, adjusts for demographics, and out pops MSGRG 871, septicemia or severe sepsis with MCC. It's like a giant puzzle coming together.
Finally, let's wrap up with Section 5, Clinical Documentation Integrity. To synthesize all of this, we have to look at CDI, the vital bridge between what happens at the bedside and how the hospital gets paid. Here's a perfect real-world example. A doctor documents incision and drainage of abscess. But remember how precise this system is? In ICD-10 PCS, you can't just drain a generic mystery abscess. You need a specific body part. So the CDI specialist sends a query. The clinician clarifies it was actually acute osteomyelitis of the right femur. Just by transforming that one vague note into a definitive diagnosis, the entire case flips from a lower-weighted medical DRG right into major surgical DRG 486. That one clarification entirely rewrote the claim.
But a quick word of warning here. You can't just list every medical condition a patient has had since 1995 to drive up the DRG weight. Secondary codes only count if they require actual clinical evaluation, therapeutic treatment, or extend the hospital stay. If a past history of, say, hemiplegia doesn't impact the current stay, it does not get coded. The documentation has to prove the condition actively consumed hospital resources right now.
So what does this all mean for us? We've seen how just choosing excision over resection or clarifying the site of an abscess totally dictates the financial lifeblood of a hospital. It really leaves you wondering just how much vital medical reality gets lost in translation every day, and how much better could our healthcare data be if we completely mastered this language? Well, I hope this helps shed some light on the subject. If you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.